Hello, welcome to all the participants. Good morning, good afternoon. We are now beginning the webinar, and the topic for this week is expanding access to mental health. We have three panelists who I will introduce in a little while, but just to give a background, the webinar series is organized by the Harvard Center of African Studies in collaboration with the Africa CDC, and they are the two organizations hosting these webinars. And the intention is to provide an accurate depiction of COVID-19 in Africa, as well as to connect with Africans and the diaspora and people around the world on issues affecting them. And today's issue is a very important one, that is mental health. So welcome again, and we are beginning now. Before we begin, I would actually like to ask a question to each of the participants. So it's an online poll, and we would like to begin with the poll. So take a moment to answer the question that is on your screens now. To what extent has your own mental health been affected by COVID-19 pandemic? And the options are not at all, slightly, moderately, severely, and very severely. We'd like to know to what extent your own mental health has been affected. But we know that globally, as well as in Africa, there is a massive impact of the COVID pandemic on all aspects of health, as well as development actually, but also on mental health. And impact on the healthcare as well as economy has been very large in almost all parts of the world. And global mental health concerns have been raised in other parts of the world, but also in Africa. And we are going to discuss that today to see how much they are, what kind they are, what could be the possible reasons, but most importantly, what can we do about them as individuals, as families, as communities, and as countries. This might have lessons not only for Africa, but also for other regions of the world. And we will try to answer the main question: how can we expand access to mental health and mental health services in the region? Let's see what the results of the poll are. If we can get the results now. So I see that the majority of people have reported that there is either a moderate or severe impact on their own mental health. It is 60% moderately, 20% severely, and at least 20% slightly. There is not a single respondent who has reported not at all. So obviously, even amongst the participants, it has been a substantial problem. Let me begin then by introducing my panelists who have very kindly agreed to come to the webinar and spend some time. I would like to begin with Dr. Florence Baingana, who is the WHO Africa Regional Advisor for Mental Health and Substance Abuse and a research fellow at Makerere University School of Public Health. You can see the detailed bios in the chat, which will be put very soon. Next, I would like to introduce Dr. Karsten Konen, Professor Karsten Konen. She is Professor of Psychiatric Epidemiology in the Department of Social and Behavioral Sciences at Harvard T.H. Chan School of Public Health. And she has been a researcher globally, but also very importantly in Africa on many aspects of mental health. And lastly, we have Professor Vikram Patel, who is the Pershing Square Professor of Global Mental Health in the Blavatnik Institute of Departments of Global Health and Social Medicine at Harvard Medical School. He is also affiliated with the Harvard Chan School, and you can find the more detailed bio on the chat. So let's begin the conversation. I would like to begin with Vikram Yu, and I'd like to ask the question: in what ways COVID-19 pandemic is affecting mental health of populations globally, and where does Africa stand compared to other regions? Vikram, please.
Thank you, Shekhar. I would like to, first of all, just to acknowledge that while I have worked extensively in Africa, I have not lived there for more than 20 years. And so I will refrain from speaking very specifically about the ground situation there, and hopefully Florence will have a lot more to say about that. I also want to acknowledge that there is a lot of data that is emerging on mental health in the context of the pandemic, but almost all of it, 90% plus, is coming from high income countries. So there's a relatively small nugget of information from the low and middle income world, and an even smaller nugget that comes from Africa. So my remarks are going to really reflect what we know from this fairly skewed body of evidence. So I think it's important to remember that we're right in the midst of the pandemic, and therefore what we can document is the acute impacts of the pandemic on population mental health. And as a summary, really, what we can see across all populations, a shift in the distribution, the population distribution of symptoms of mood and anxiety, and in some cases, trauma-related mental health experiences, so that the entire distribution that you would see in the population has shifted, as it were, towards the unhealthy or unwell end of the distribution. And obviously, when that happens, one would also expect to see increases in the actual prevalence of threshold level mood and anxiety conditions, as well as self-harm thoughts and behaviors. And indeed, from those settings in which we do have empirical data, such as in the US, there is very good evidence that that is happening. In the US, the CDC published data, now this is already a couple of months old, showing dramatic increases in the prevalence of mood anxiety disorders and suicidal attempts in the previous 30 days before the survey was done. Now, it's also important to remember that this impact is not equitably distributed as all mental health problems. There's a disproportionate impact, but in the context of the pandemic, it's important to remember certain vulnerable groups, particularly low-income populations, young people, and we can talk more about young people as a very important demographic for mental health problems more generally, and women. Again, we can talk about that later on. Shekhar, I wanted to draw your attention to perhaps the most important paper of all that I have seen, which is actually not yet available in the public domain. I think it's certainly available in an online form in World Psychiatry, which I think is the largest study ever that I have known on COVID-19, involving the electronic health records of 61 million, yes, 61 million adult patients drawn from across 50 states of the US, 360 hospital systems, up to July the 29th of this year. And it has astonishing findings, which I think is really going to change the conversations about the importance of mental illness in the context of COVID-19, which is summarized as follows. People with a recent diagnosis of depression or schizophrenia had a sevenfold increased risk of being infected by COVID-19. Amongst those with a recent diagnosis of a mental illness, African Americans and women had a far greater risk of having contracted COVID-19. So there was an interaction between having a mental health problem and historic disadvantage, demographic and social characteristics. And thirdly, and this is perhaps the most important finding of all, that patients who had both a mental disorder and a COVID-19 had a double rate of dying. So this is an astonishing piece of work, not just for its size, but also because of its dramatic findings. And I'm sure over the weeks and months ahead, there'll be a lot of analysis of what is going on here, but clearly indicating that mental illness isn't just a consequence of COVID-19, but in fact, as a comorbidity, doubles the death rate and increases the hospitalization rate as well. I also want to end by saying, we have far little data, not only on low and middle income countries more generally, but also on children. And I think it's important to point this out because, children have been hugely affected by the pandemic, but we have almost no data on children's mental health and well-being. And finally, of course, we need to be mindful about the long-term mental health consequences in light of the fact that the economic recession, which is a major social determinant of poor mental health, is going to be profound across the world and again affect low-income populations disproportionately.
Thank you very much, Vikram, and also for pointing out that the relationship between COVID-19 and mental health is a bidirectional one, so that people who are already having a mental disorder have a much larger prevalence of getting infected and also having severe illness and even dying. So this is quite important, and also for pointing out that mental health problems have increased in the community in the as a correlate of the infections going up. Africa figures, which were presented actually at the beginning of this webinar in a slide, are also showing that although the prevalence has been lower than some of the other regions, it is still quite substantial. And the mental health impact have not been perhaps measured as well, but are likely to be quite good. But based on your research, Vikram, what, based on your research as well as your colleagues, what evidence-based solutions would you recommend to strengthen the mental health delivery system in African countries, which, as you know, are starting from already very ill-resourced and in some way very ill-developed mental health care system? So what would be your recommendations? Also keeping in mind that Africa has much younger population, and the importance of strengthening the system using evidence-based interventions.
Yeah, well, actually, Shekhar, you and I were involved, along with Florence, in fact, in producing the Lancet Commission on Global Mental Health and Sustainable Development. And I think that really has done a fairly good job of synthesizing the innovations in improving access to quality care across contexts. And I think, by far and away, the most important intervention delivery systems are those that use star sharing to frontline workers, of fairly parsimonious psychosocial interventions. There are many good examples actually from Africa itself. The Friendship Bench, which originated in Zimbabwe, the Common Elements treatment approach, which originated in the US but has been now adapted for many African settings, interpersonal therapy, the behavioral activation treatment called the Healthy Activity Program that we developed in India is now being rolled out in Malawi and in Uganda. So I think there's many approaches, and I think all of them, as backed by randomized control trials, of course, have transformed our understanding on how we can deliver mental health care in any context, regardless of how many mental health specialist resources we have. So I think this is the most exciting evidence of all. Obviously, scaling it up does require many other pieces to be put together, much beyond the evidence of effectiveness. But I think it's important to recognize that without the evidence of effectiveness, you would have no real support for scaling up. So I think this is an important piece to acknowledge. I also wanted to say something beyond the use of psychosocial interventions for people with mood and anxiety problems, because of course, almost all the evidence I've referred to comes from that particular set of mental health conditions, and recognize that people with serious mental illness often tend to get forgotten. Even it's interesting when we talk about the impact of the pandemic on mental health, actually most of the conversations are really around population mental health, mood and anxiety symptoms. But I think we need to acknowledge that people with serious mental and enduring mental health problems are often completely ignored, stigmatized. They are the ones who are actually hidden completely from view. And I think the pandemic has affected their care because of the closure of mental health services in many parts of the world. And we don't actually know what impact that has had yet. I haven't seen any proper documentation, for example, of mortality in people with serious mental illness in the last 6 months. But I would be worried about that particular issue. And I think within the broader low and middle income country world, we need to recognize the need for a rights-based approach that really ultimately seeks to minimize involuntary treatment. And I think we know the strategies that work. Again, the empowerment of people with the lived experience to be at the heart of all mental health programs, and the implementation, of course, of the quality rights initiative that you, Shekhar, as the head of WHO, really were involved with setting up. And I think that's a really important piece as well.
Thank you, Vikram. In fact, you referred to the need for monitoring the situation, how healthcare systems are being affected by COVID. And actually, that's a very good point to bring Florence into the discussion. Florence, you work for WHO, and WHO has been actually monitoring the situation of mental health systems even earlier, but also has made a very good attempt, as far as I understand, for measuring the impact of COVID-19 on the healthcare system and mental health care system in countries. So how would you describe what you have found in the African region?
Thank you very much for inviting me to be a panelist on this exciting webinar. Yes, indeed, WHO carried out a study to determine the impact of COVID-19 global. It was a global study. For the Africa region, we have done a sub-analysis. For the global results, you can get those. They were disseminated on the 5th of October, I believe, 5th or 6th of October. But the Africa region results will be out very soon. So 28 out of the 47 African region countries responded. As you can understand, the Africa region lagged behind the rest of the world in how the COVID impacted us here. And therefore, when this survey was carried out, we were actually quite impacted and trying to respond. And that could have explained why we had such a low, not so low really, over 60% response rate. Some of the key results are in 3 broad areas. In all countries of the African region, the Ministry of Health is involved in the mental health and psychosocial response. So for the whole region, whether there is a mental health technical working group or not, the Ministry of Health is actually involved in the response for those countries that responded. However, and all these countries also had a mental health and psychosocial plan developed to respond to the COVID. However, only about 25% of the responding countries had allocated additional government funding for the plans that they had developed, and a further 38% had provided partial funding. So while the countries may know what to do in that they develop plans, but they are not able to respond fully because of the lack of resources. The second one was on the service disruptions in the Africa region. The biggest service disruptions were seen in the area of substance use, as well as school and work-related mental health. As you know, in most of the African region, schools were closed and workplaces were closed and left only for essential workers. And so as a result of that, many people could not access mental health care if they were to get it through the workplace or through the school. The causes of disruptions were also very similar. Inpatient volume cut down because of travel restrictions, insufficient PPE, personal protective equipment, and unavailability of health products. These latter two stood out for low-income countries for the African region. So again, it brings out that lack of funding, the economic situation, the low income of our countries. And then the approaches to overcome the disruptions were similar at the global level, as well as to the Africa region, including providing helplines and strengthening measures for infection prevention and control. However, at the global level, there was a much bigger focus on telemedicine, investing in telemedicine and teletherapy, and this stood out, as well as self-help or digital formats. As you know, the coverage in the Africa region of smartphones and computers, and as well as those who are skilled to provide this kind of intervention is lacking, and it also requires resources. So to conclude, economic issues or limitations run through how the Africa region findings differ from the global level findings, from the funds allocated to the response, as well as to the causes of the service disruptions. Thank you very much.
Thank you, Florence. That really illustrates that the countries and the governments are becoming very aware of the mental health needs, but they are unable to find at this point of time the resources to do something which will be absolutely necessary at this time. But working for WHO, what has been the WHO's response to in this region to the situation that is happening now? To what extent WHO has been able to assist the member states in relation to strengthening of the mental health system, and how will it contribute to what has been described as building back better, because the systems were anyway weak and they are becoming even less strong now. So how is WHO assisting the countries in doing that?
Okay, thank you. So the WHO response is at 3 levels, as you very well know. We have the global level, we have the regional level, and we have the country level response. So at the global level, WHO developed the clinical guidelines, and mental health and neurological disorders were included in the clinical guidelines developed. Other guidelines were developed, such as basic psychosocial interventions, psychosocial support, and these were disseminated globally. So they were sent to the Afro region, and we sent them out to the countries. Another support was the book developed for children, My Hero Is You. And I would encourage everybody to look it up. It's very exciting to see the number of languages and dialects that have been translated. It's a book that parents can read to their children to help them understand and cope with what is going on right now. So those were at the global level. At the regional level, we also developed and disseminated guidance for the general public, and then specific ones for people with NCDs as well as mental health. So for instance, some of the issues that Vikram just raised in relation to how people with mental disorders may be more at risk to COVID or more at risk to death from COVID, some of these were also highlighted and put into the guidelines to ensure that care is taken, to ensure that people, especially those in institutions, are kept safe. We also developed guidelines for healthcare workers. Some sub-regions like the Eastern Southern Africa sub-region carried out a survey. This is the UN team in the hub in Nairobi carried out a survey and then developed a guideline for basic psychosocial support for point of entry personnel, because we have a lot of movements on the road and there was a need to provide support for the people who manage the people who go through the borders. In some countries, WHO funds are allocated for emergencies. So every time there's an emergency, there's a sum of money that becomes automatically available. And for some countries, this amount some of it was allocated to mental health and psychosocial support. It is used for MHGAP training to strengthen delivery of services at lower levels of care, as well as psychological first aid, especially for the responders. In relation to the building back better, the mental health psychosocial response in emergencies often catalyzes the Ministry of Health to strengthen mental health provision. So for instance, a person can, sometimes following an emergency, a person is allocated to the Ministry of Health, or a desk is established, or the mental health area is strengthened. We have evidence of this, like following the Ebola epidemic in West Africa, in Northeast Nigeria. The 3 most affected states there have actually developed strategic frameworks. So this is one response, as you mentioned, to the building back better. For COVID, we haven't quite seen it because we are still in the middle of grappling, trying to control the emergency. But I believe following this, we shall be seeing some of that as well. Thank you.
Thank you, Florence. And also thank you for alerting us to the beautiful book, My Hero Is You, which is excellent. I've read it many times and I would recommend it to everybody. In fact, I would like to request the technical team to find the link to that and put it on the chat if they can. It's My Hero You from WHO. And also, actually, there is also a video which has been made based on the book, which I was actually fortunate enough to be involved with, that also has a link on YouTube, and it will be useful to have that. So thank you very much, Florence, for telling us about the efforts that member states are making, but also what WHO is doing. I now would like to go to Kirsten and talk a little bit about research, because services are important, there are increasing needs, but Africa has been also supporting a lot of research in the area of mental health, and Keriston has been in the middle of that and actually has continued through the COVID. So tell us what has been your experience of conducting research in mental health facilities in Africa during the pandemic, and what has been your experience of doing it remotely and sometimes using the local people who are there. Can you unmute yourself?
Yes, you'd think I would know to do that by now. And I'm just want to say I'm really honored to be here with Shakara, Florence, and Vikram. Thank you. So to try to provide a little context, so in my role in this panel, I am one of the leads of something called NeuroGap, which is Neuropsychiatric Genetics in African Populations. And the goal of the project is to improve equity and reduce disparities in genetics research in Africa. And I'll provide a link. We just released this is with the Harvard School of Public Health and the Broad Institute, and they just did some great videos at the Broad on this. So I'm just gonna release a link in the chat to provide more about the studies. But in terms of where we are, we're in South Africa, Uganda, Kenya, and Ethiopia. And so talking in that context, so we have this very large scale study. Our goal, we've enrolled 19,000 Africans across those countries, and our goal is 35,000. So it's a very large study. And so in terms of during COVID, we went through with our local sites as the pandemic was sort of emerging and realizing it was going to be global. We, we're really lucky because our research is really built on the relationships we've developed with our local collaborators. And so as the pandemic was developing, we really, our local PIs really take the lead on how things are done locally. Because obviously I talked about 4 countries, even within those countries, how COVID has affected South Africa versus Kenya versus Uganda versus Ethiopia is very different. And then if you're talking within the countries, things are very different. So we have our great local leads, and in all cases, they decided to shut down enrollment of our studies before they had to. And so we went through that with the local IRBs and the Harvard IRB. And then through the pandemic, we were very fortunate that our funding, we have multiple funders. We have National Institute of Mental Health, but also the Stanley Center and other money that allowed us to continue paying staff during the shutdown. So I just want to mention that was critical, that people could keep their jobs and we could sort of retask what they do. So all studies were shut down for some period, and then slowly they have been restarting again in Ethiopia, in Uganda, and one of our sites in Kenya. One site isn't. And it's all been led by local infection rates and what the local IRBs will allow, and then what our local PIs are comfortable with. So sometimes they might be allowed to enroll, but they won't follow through. And during the time of shutdown, the project manager team, which is, we have a couple of people in the US, but in Africa and at all our institutions, work together to develop COVID protocols for enrolling. So it's recognizing that this would continue to be a problem. What do we need to do? We need to buy PPE. Part of our study is we collect DNA via saliva from people. So you actually are kind of closely interacting and with biological specimens. What do we do? Luckily, our labs were already set up to deal with this kind of thing because of concerns locally about malaria and TB. So some of the precautions we used for that worked for COVID. And so that was, so there was a lot of work on protocols, and then we could institute the protocols as we ramped up again. And so we, like I said, we are continuing now. We are, it really, where we're enrolling totally depends on local conditions and can change at any time. So it really depends on these relationships and this relationships of trust between us and our collaborators. And the fact that we always want to make sure that the health and safety of our study participants and our staff are number one, even if it means we have to, the study will take longer or whatever. And our flexible funding has really allowed for that. Because I think one of the risks with the kind of work we do is that funding pressures can influence people to make, poor decisions. And so we've been fortunate that that hasn't been the case in our case. The other thing I just wanted to mention related to what Vikram spoke about is we're studying psychosis. So schizophrenia and bipolar disorder. So we're working in hospitals that mainly focus on those conditions. And I will say in all sites that reopened, this is anecdotal, I don't know about the data on this, they saw an increase in case numbers, a rapid increase in case numbers on reopening. And that could be people who sort of relapsed because, as Vikram said, their facilities were shut down, so they couldn't receive care. And then also there is evidence that extreme stress and trauma, that in some cases is related to psychotic episodes. So we do see an anecdotal impact, but as Vikram said, the data from low and middle income countries and in the African context is really limited.
Thank you so much, Kirsten. You have very clearly highlighted the ethical responsibilities of researchers, but also research funders,
right,
when such a humanitarian crisis becomes very obvious in the study sites. Would you tell us if there were any expected or perhaps even unexpected benefits in case of research capacity building as you went through the pandemic? Any experiences?
Sure. Yeah, I'd love to share a little bit about that. I'll give you a very specific example. So the kind of research, I actually, to step back, I'm a licensed clinical psychologist and I also do treatment work. So I have I feel like the neuropsychiatric genetics research is really important and critical, especially for the long term. And again, I'll share that in the chat so people can look in more detail at that. And I won't spend time here going into why so much, but I feel this pull because treatment research and treatment work is so important and so urgent in the immediate. But in the process of setting up this large study and these collaborations, I have, for example, in Ethiopia, and this is true in, I think, all the countries we work in, that the IRB, because we collect biological specimens, the national IRB has to review everything. So it's not just a situation like for people who work in the US where it's your local Harvard IRB or MGH IRB, but we have to go to the national IRB. So in Ethiopia, there was a lot of concerns based on their experience with previous biological research in Ethiopia. They'd experienced what I like to call scientific colonialism, where Western researchers, usually US or UK, came to Ethiopia, did genetics research, took their samples, took their data back, and never even let the investigators know, or the local investigators would find themselves on a paper or whatever. So there was a lot of skepticism and lack of trust. So from the national IRB and from the Ministry of Science and Technology. So as part of setting up our study, I had to go and speak in front of the national IRB and answer their questions. And one of the arguments my local collaborator, Dr. Solomon Tefera, and I made was that, this type of research is critical for the advancement of science, but also that there will be long-term unexpected benefits. And you believe that, but in COVID, we found a very concrete example. So in Ethiopia, we helped to set up local labs. So in all our studies, the DNA is extracted locally and kept locally, and then a portion of it is sent out for, let's say, some kind of analysis. But in all cases, the local collaborators and institutions hold the DNA. And so we helped build these labs. There was a sabbatical program where people from the Broad went to Ethiopia, worked with them very closely to help develop the labs. And we made a very small infrastructure investment. It was just getting some freezers. Well, the labs that we collaborated on building are being used now for COVID testing in Ethiopia. So that was, and have made a certain amount of COVID testing possible that would not have been possible if we hadn't built up these labs with our collaborators, if they hadn't been developed. So that was a very sort of concrete example of how something we never anticipated, I was not thinking of that as a benefit, actually had an immediate benefit in the pandemic. And so I hope, we'll see more of that, but it's nice to see, it was nice to see that I said that and it actually bore itself out. Because you believe that, I believe that as a scientist, but you sometimes think you're thinking decades. And unfortunately with COVID, we actually had the opportunity to see this recently.
Thank you so much. It's so interesting to see that sometimes a crisis can be an opportunity if you put it in the right way and take advantage of that. Obviously, it's a catastrophe, but maybe there is some silver lining in some spheres. Thank you so much, Gariston, for sharing your experiences. Vikram, I want to come back to you and refer to your earlier remarks about expanding services and increasing capacity, and also Florence's remarks about the use of technology, how obviously it's expanding, but still Africa is not perhaps as connected as some other parts of the world. Vikram, what do you see as the opportunity for the use of technology in directly delivering services, but also in increasing capacity of the care system to do the right things which are evidence-based?
Thanks, Shikhar. That speaks directly to a subject that, as you know well, I am very, very passionate about. So first of all, I want to, concur with what Florence said. This question about the digital revolution is a very, it actually needs to be seen in the context of access to digital technologies. And it's not just in Africa, but even here in the US, let's be absolutely clear, there is no universal access to high-speed internet. And so I think we need to acknowledge that there are historic inequalities that are completely overlapping with social class, and in some parts of the world, there are other kinds of structural inequalities. And the digital revolution is actually risking expanding those inequalities. So for example, in the case of schooling, I was recently shared some data from India that showed that only 10% of Dalit children, Dalits are the most disadvantaged, historic disadvantaged community in India, only 10% of those kids live in families that have internet. So, this whole shift to online education actually means that 90% of a historically disadvantaged group actually has no access to any education. So, those of us who think that the digital revolution is going to change the world really, really need to actually have a reality check on this. And the same applies to mental health care. Telemedicine has become a very big platform. And by the way, I do celebrate it. I do think it's a good idea. I do think for those who have internet access, it's terrific, because it means you don't have to take a risk and go and see a provider in person. But actually, the vast majority of people in India, and I don't know about Africa, Florence will know better about coverage rates, actually don't have access to the kind of internet you need for telemedicine. It isn't just actually downloading WhatsApp messages. You need a pretty good quality internet coverage for live streaming like this. So let's keep that in mind. So what we are doing at the medical school, we have this program called Empower, which is actually wanting to use digital platforms not to directly deliver services, but to actually build a workforce. And we argue that the workforce is potentially one segment of every population that actually is more digitally empowered, because actually a lot of healthcare is now being done through smartphones, and there are a lot of different digital platforms. So what we're doing is developing curricula and supervision systems for frontline workers so that we can scale up evidence-based psychological interventions such as problem solving, behavioral activation, and so on, so that we can build a workforce. So a digital idea is not about delivering directly self-care interventions or telemedicine. If that's great, if that's available, that's great. But it's actually targeting the health system to improve its capability to deliver and scale up mental health care.
Thank you very much, Vikram. That's very useful, because there are already many instruments, manuals, and intervention guides which are there. But the problem is how to actually use them to train the trainers. And that is something which is important. And also train the service providers who may not be accessible. And that is, I think, a very important way of scaling up the capacity for service delivery, which is extremely useful in all parts of the world, but also in Africa. Just a note for all the participants, we will have some time for questions, so feel free to put some questions in the Q&A section. and we will take up at least some of them. But at this point, I want to go back to Florence and ask her a question. WHO is there to provide technical assistance to countries and also to guide what they should be doing. So as a WHO staff, what will be your recommendation to the Ministries of Health, what they can do to strengthen the mental health care system in their countries immediately, as well as with medium term in mind? Florence, can you unmute yourself?
Sorry, sorry, yes. That is an important question. Very sorry about that. Yes, WHO is primarily in countries to support the Ministries of Health. I would urge the Ministries of Health in the Africa region to ensure that they establish or they strengthen the mental health, psychosocial, technical working groups. And they also need to ensure that they're actually participating in these technical working groups. We have countries where the Ministry of Health may not be an active participant, and yet we want the Ministry of Health to be in the driver's seat, because as we said, if we want to be building back better, it will only happen if whatever is begun now during the pandemic can be built on the infrastructure of the public health system of the country, so that you strengthen that. And then after the pandemic, we will then have a stronger mental health system that can only be done with the participation of the Ministry of Health. We'd also like the governments, the Ministries of Health, to increase allocation to mental health and psychosocial programs and plans. For instance, for the training of psychosocial workers, of mental health workers. Very often there's a very nice plan that says we shall have a clinical psychologist or a counselor in every treatment center, but then the funds to pay the allowances of these counselors are not there. Many countries actually do have the personnel, but it's the funding. They are not being paid to provide the service, which is a big challenge. We also need the lines to be funded. If people are going to call in and it's going to be toll-free, then somebody has to pay that money. So all these will require some funding. And I don't think it's a lot of money. We are not asking that you train psychiatrists right away. That may be later on, or clinical psychologists or psychiatric social workers. This may be later on. But for the immediate, we just need allowances to be paid for these key mental health psychosocial persons, as well as supporting the activities that they carry out. Thank you very much.
Thank you, Florence. I do want to come back to you, Cariston, with another question. And we all know that COVID-19 is putting a lot of barriers in conducting research as well as providing services. From your experience of many years, how would you see some of the threats as well as the opportunities for research in the African region related to mental health? And also, in what way can research actually be integrated with the services so that we don't see these things as two separate things, but really integrated so that there is research capacity building, research findings, but also better services?
Yeah. Well, those are good, great questions. There's a lot there that I could unpack, but and so in terms of some of the, I'll start with some of the opportunities. Something our colleagues have spoken about, our colleagues in Africa. So the PIs of the principal investigators of our studies in Africa are all psychiatrists, some with PhDs, but also are embedded in services. We collect, all our data is collected in mental health facilities or other kinds of medical facilities. And so one of the things our psychiatrist leaders have said to us is that they have never have had as much interest from their medical colleagues in mental health as they have during COVID. So they said no matter, even though that many of these are very prominent, some of them are deans of their institution, they said they saw a phenomenal increase in interest in medical colleagues who normally dealt with cancer, cardiovascular disease, in mental health, and much more action and conversation. So that to me presents a potential opportunity going forward. We'll see where that goes, but that's one opportunity. And then the other thing we've seen in terms of opportunities is, for example, on our research studies, the psychiatrists and clinicians and staff that we work with are at Makerere, we're in Budabika Hospital, or in these facilities. And a lot of the skills that they learn in research are actually applicable to clinical work, even though we're not a treatment study. So for example, using like locally validating instruments, so we have well-established instruments, translating them and validating them or dismissing them if they're not useful locally, training people on how to administer well done interviews, well structured interviews, and how to collect data systematically and how to track that and all the procedures. And we've had report after report from our project managers, who are actually usually people who eventually want to go into medicine or other clinical fields themselves, about how invaluable the experience of training on a research study has been, either for their clinical work or for their future, how they think about their practice in the future. So I think that these things aren't separate at all, especially when you're working in local facilities. Also, off of our research studies, there's been a lot of interest, for example, in providing workshops and evidence-based treatment, some of the ones that Bikram mentions, the common elements, treatment and things. And so we've been able to, because we have clinical psychologists and folks who work on the treatment side in our team, we've been able to collaborate locally with providing resources for clinical treatments, even though, again, we're a research study. So there's not this clean, it's not like where we work, they're not separate things at all. In terms of challenges, one of the biggest challenges, I think, is that the urgent will push out the important. There are many, and I'm not going to go into it too much on this because it could be a whole webinar in itself, but there are many really important long-term reasons for the African continent, but for the world in general, of doing sort of neuropsychiatric genetics research in Africa. But the gains are long-term. And so, and I feel the same pull. There's such urgent current need, and how do you balance that with the need to do this sort of longer term research? And I think one of the ways you do is to not see them as separate, is how can the research that will have long-term benefit have some immediate positive impact? And the other challenge I see is the need to cut back on all the things that make the kind of work we do, like relationships and trust and resources are really critical for the kind of work we do. And I feel that all challenged by COVID. One, because we spend a lot of time in Africa on the ground with folks, and now like Harvard doesn't let me travel. We actually applied for travel exemptions and got it, so some people will be going, but that hurts. Even though we can be on Zoom, that hurts. That's hard for the relationship. And because there's such pressure to kind of show results, there's the we need to make sure that we're keeping people safe, and also, maintaining equity in our collaboration, so that that's been a principle so far, and that we're not somehow trying to like cut corners to kind of get something out that will, impress funders. And again, I can't say enough about the importance of funders' flexibility in these situations to maintain the work, but also maintain the relationships and to the investment that we've made so far. And then finally, I guess just to mention, I would say the biggest challenge we have in our trying to build capacity and equitable partnership in the places we're working is the digital divide. We can provide all the training, doing genetics research there. We've got, our partners have that, that's great. But it's still a challenge when for example, people learn to do genetic analysis, all the analysis being led by local collaborators, and they don't have a good enough internet connection to actually work with the genetic data. That has been, I think if I could change one thing, do one thing that would improve our research, it would be to address the digital divide. Yeah.
Thank you very much, Kirsten. We still have time, so if any of the participants would like to ask a question to any of the panelists, please post them on Q&A. I have two questions already from another source, and I would like to ask the first question to Vikram. Maybe later on Florence can also add to that. The question is that besides providing treatment for people with mental disorders, what could be some of the upstream interventions that can be done by the entire government rather than just by the Ministry of Health, which could actually prevent people experiencing mental distress and disorders? And how would you see that in the context of Africa?
Yeah, that's a really good question, because actually I don't think that without prevention we will ever be able to reduce the burden of mental health conditions. So, the conversations have been focused on people with mental health problems. So therefore, but even in that group, prevention has a very important role. So I don't want to minimize that, particularly prevention of, secondary problems associated with mental illness, physical health problems that go and so on. But I think the question is really about primary prevention. And I think it's absolutely correct that we need to be thinking about primary prevention. And it's also correct that most actions for primary prevention lie outside the health sector. And so oftentimes when we talk about primary prevention in the mental health field, unlike many other kinds of medical issues, say, for example, the prevention of cervical cancer, where the preventative intervention is also medical, in a sense it's a kind of an immunization against a virus. Actually, that is not the case for mental health problems. For mental health problems, the primary actions are, for example, creating nurturing environments for children and young people. These are the 2 decades of life where, what we have such strong evidence, of adversities in childhood and adolescence being amongst the most universal risk factors across all mental health phenotypes. That's the other interesting thing. It's not even specific to one or another condition. Of course, there are some genetic variabilities as well, but adverse childhoods are a huge factor. And so I would put all my money in prevention around early life parenting interventions, the ones that we associate with early child development, but also more broadly than just a narrow focus on cognition, and on creating very promotive environments in schools, starting from the earliest school years all the way through into colleges. These would be my biggest investments. And of course, that means working with ministries that work with early child development and women's empowerment, as well as ministries of education rather than health.
Thank you, Vikram. Florence, would you like to add anything?
Yes, I would like to. Just like Vikram said, there's a lot that can be done that may be outside of the healthcare system, but could also be within the healthcare system. This includes immunization. If every single child was immunized, we would have, I believe, less occurrence of neurological disorders like epilepsy, for instance. Reproductive, maternal, neonatal, child and adolescent health, these are really important, especially child and adolescent health, as Vikram has said. Prevention of intimate partner violence. That too is really important. And then strengthening and protecting the rights of women per se. Access to land, access to livelihood, access to their own incomes. There are women who work, but the income belongs to the husband. So all these kinds of things would go a long way to preventing mental disorders. School mental health programs that are universal, but also targeted to those who are most at risk. And early child programming, that too would go a long way. There's a lot of evidence to suggest that school mental health programs in later life actually prevent a lot of mental health problems, but also in improving livelihoods. Others include housing as well as ensuring livelihoods. And I could go on and on, but I think I'll stop there for now.
Thank you very much, Florence. There is another question which has been raised, which is more specifically about the mental health and well-being of healthcare providers, which is a very specific area. But we do know that Africa has a very large gap between the numbers of healthcare providers who are needed versus who are there. And they are in some cases working overtime to provide the kind of care that is immediately needed. What is the impact on their own mental health and well-being? And what could be the immediate as well as somewhat longer term effects if we do not look after the mental health of the care providers themselves? Florence, you first, and then Vikram, if he has anything to add.
Okay, thank you very much. As you rightly said, we do have a big gap in the number of health workers that we have. If we look at the mental health atlas data, which is available on the web, you will see that Africa has about 0.9 of a person per 100,000 population, and these are the mental health workers. So if we think about what is happening now with the COVID, because some of them had to be repurposed to COVID, therefore we have fewer people attending to those who have pre-existing mental disorders. But even those who go into COVID care and the general health workers who are providing care within the COVID healthcare system, the response. Many of them are working long hours. Many of them are working without the full personal protective equipment. A lot of them have not received the allowances that they were promised, and therefore this makes their working conditions very, very difficult. And so you hear of stories where you go into a treatment center and the healthcare workers are not very nice. And yet for people to agree to go into a healthcare center, they need to believe that they are going to be treated well. If people believe that I'd rather stay home rather than going to a hospital where they are going to mistreat me, then that's going to be a problem, because then people stay in the community and they spread the virus, which is not a good thing. So I think because we are not treating our healthcare workers right, and maybe also not providing, if not every single healthcare worker has gone through psychological first aid. If they go through psychological first aid, they learn how to recognize their own distress and recognize distress in others, and they also learn how to communicate compassionately. And this too, again, helps not just themselves, but their fellow healthcare workers as well as the patients whom they help. So I'll stop there for now. Thank you.
Thank you, Florence. In fact, I do know that your own experience with the response to the Ebola was actually also very useful in preparing those countries as well as WHO to look after the safety, the mental health, and the well-being of the care providers, which is very important. Vikram, anything to add there? I think as we come to the last 2 minutes of the webinar, I would like to ask each one of you, each of the panelists, about one take-home message. If there is one thought that you want to leave behind with the participants, what would that be? And I begin with you, Keristan, first.
Thank you, Shakar. So I've been thinking about this, and I guess the one take-home message I have is that I think we in the US may have a lot to learn about COVID, and also about addressing mental health needs at a population level from all the work that's being done in Africa. And that is something that I continue to sort of appreciate and sometimes be surprised by as I do the work in the places I work, is that we have actually, in the kind of work I do more on the genetic side, we have transformed some of the ways we do things at the Broad because of what we have learned on the ground in the labs in Ethiopia, Uganda, and Kenya in particular. And I think on the treatment side as well, as Vikram mentioned, some of the things that have been used and shown to be efficacious and have evidence from the African context, sometimes in the US we're resistant to thinking they have lessons for us, but I actually firmly believe they do, especially on the prevention and sort of population mental health side.
Thank you very much. That's an excellent message on a bi-directional flow of knowledge and experience, which is so very important. we are running really out of time, but I do want to give you the floor, Florence, and then to Vikram for one last comment as the take-home message.
I'll be very brief. The one take-home message for me is that there is an increased need for mental health services, and therefore there's an increased need for investments in strengthening mental health systems in Africa. That's it.
Vikram?
So I want to just finish by saying I think this is a historic opportunity to invest in mental health care, but I think we need to not just ask for more money, we should also be spending it wisely, guided by the best science and by human rights perspectives, which means that mental health care must embrace a diversity of experiences and strategies which work beyond a narrow biomedical approach.
Thank you very much. And I, at this point of time, would like to thank all three of you, the panelists, for giving us such good insights, and also all the participants. But I also want to announce that this webinar series will continue. And the topic for the next one is youth and closing the innovation gap. So do join in. There will be the schedule of all the webinars on the website, africa.harvard.edu. And also reminder to the attendees that they should, if possible, fill out the post-webinar survey that will appear once they exit the Zoom screen. And again, the dialogue will continue in a variety of ways, but it has been very good to discuss mental health in this series. Thank you everybody for joining in, and that's the close. So thank you. Bye-bye.
Thank you. Thanks, everyone.